Hello, so we're here for some mental health training again, and we're going to talk about emergency sedation in the acute hospital today. So my name's Emma Phillips, I'm one of the liaison psychiatrists in the hospital, and I'm here with my colleague.
Hi, I'm Dr. Jessica Harris, and I'm another consultant psychiatrist who works here in Gloucestershire Hospitals.
So, emergency sedation. I suppose the first thing that we ought to talk about is what does actually emergency sedation mean? So I suppose the obvious bit is, as its name suggests, it is for use in emergency settings. But there are a few other names that you might come across that are similar, aren't
Yes,
there? Yeah.
Particularly in the mental health setting, we often called this in the past rapid tranquilization. So these are very big words.
Yes.
They do suggest that something very dramatic is happening and possibly something dangerous, and that it's a great big emergency.
Yes. So I think it's, I often think that both of those things are a little bit of a misnomer, aren't they, really? Because sedation implies that you're trying to make your patient go to sleep.
Yes.
And rapid implies that it's going to happen very quickly.
Yes.
I think often with the emergency sedation that we use most regularly, neither of those things are especially true.
Yes, so this isn't a process to try and make the patient go to sleep and therefore the problem go away. This is about reducing risk.
Yeah.
Risk or distress, and maybe to the patient, maybe to the wider environment. But it's not about making the patient go to sleep. It's about changing the situation and that person's behaviour to make it more safe. And as you say, this is not the same as a patient going under anaesthetic where they might become unconscious. This is a process that can actually take many hours and has many stages to it.
Yes.
Before you can say that the process is complete.
It's worked, yeah. So there's specific sort of nice guidance around what emergency sedation is, and the specific sort of terminology they use is the use of medication to calm or lightly sedate a patient to reduce the risk to themselves or to other people, allowing reduction in agitation and aggression to allow medical evaluation to take place. So that's what NICE say about emergency sedation. So like you said, we're not thinking about anaesthetising the person, we're thinking about light levels of sedation, so the person should still be alert, most likely, and able to move around, but less agitated than they were before.
Yes.
So that's the aim. So, as you said, in mental health settings, we sometimes call that rapid tranquilization, but they're largely the same kind of processes, aren't they? When would we actually see it used, emergency sedation like this?
So in the acute trust, we see this in several areas most commonly. The one that everyone thinks about first is a patient who has got a severe mental illness and they need to change the way the patient is behaving. And it might be that we use emergency sedation on a patient who's come in perhaps to the emergency department or in another quite acute setting. They're new to the trust, there's something wrong with their mental health and they're very agitated or perhaps even being aggressive. Certainly it's a dangerous situation for them or others, and we want to try and change the level of risk that everyone's facing.
Yeah.
But we actually use sedation in patients who may have no mental health background at all. Patients become confused and the risks can go up for the same reason, and we might need to use
delirious patients
there. We also sometimes have to use emergency sedation if a patient is just becoming exhausted. If they're very confused, sometimes you see that with older patients, something needs to change because the consequences of a repeated behaviour are becoming more serious.
So the consequences might not just be that they hurt themselves or others, but actually their physical health is deteriorating as well, because of their levels of
patients
agitation.
who can be really agitated can actually damage their muscles. They can have other physical consequences. They can become dehydrated. So it's worth thinking about what the patient needs. And distress also matters. You can give someone emergency sedation if their distress levels are so high that there is damage.
Well, that's a risk, isn't it? That's a psychological risk, yeah. So I think, like with everything, and hopefully you've seen our podcast about the Mental Health Act as well. Not that we necessarily always use the Mental Health Act for this, but we always ought to think about what legal framework we're using to treat these patients. So, one of the first things I think that needs to happen if a person is so agitated that they might need emergency sedation is that at least some attempt is made to assess their capacity about what's going on.
Yes, and to talk to them about that and see if they can understand that you want to give them something. It might be medication, it might be a move to a different environment, it might be all the things that could help in the situation, but can they talk to you? Can they understand what you want to do? And are they able to consent.
And if they are, that doesn't mean that you can't give emergency sedation, does it? But it might mean that you use an oral route or that you're talking to them about it. But you should always have some idea about what their capacity is and make sure that you've documented that in the notes in the first instance. If you think that they don't have capacity, are there other things that you should do around the emergency sedation, do you think?
We need to have a think about what's going to be in their best interest. So you keep focused on the patient to start with, but it also means you need to be starting to think about which clinicians are going to be involved in the situation. There is a policy that you can have a look at. It's a very short one. It can be thought of and reviewed quite quickly, even in an emergency situation. And if you're starting to think about sedating someone, you need to be bringing in senior clinicians and the site managers. And you certainly shouldn't be managing this if you're a junior member of staff. No,
so getting in the right members of team. So there's the site team are helpful again, aren't there? Perhaps your own senior clinicians, whether that's the med reg or a consultant who's around, or say you're on the paediatric ward, hopefully maybe the paediatric registrar or consultant.
And I think that's important because a situation like this might well be stressful.
Really stressful.
And it's important because a situation that's very stressful, it can be difficult to think things through clearly. It can be easy to miss important stages in trying to improve the situation. And having senior support and other people means that you have created that space, you have created that teamwork to think through what you need to do for the patient.
Yes. So if the person doesn't have capacity and you're thinking about what's in their best interest, the other thing that's important under the Mental Capacity Act is that you use kind of the least restrictive options available, isn't it? And so medication, or particularly, if you need to use IM medication that we'll get onto, is a fairly restrictive thing to do. So we need to make sure that we've done all the less restrictive things first. So emergency sedation is only something that you should really think about as long as it's safe, if you have tried to do all the other things first. So sort of you talked about perhaps moving people to a safe place or a side room, trying to keep staff consistent.
So we call that de-escalation, don't we? So there's things that you can sometimes change which will make a really big difference. If a patient has got a significant mental illness that's contributing to the situation, or if they're a patient who's confused, or if they're a patient with a learning disability, often thinking about the environment and who's looking after them can go a long way. And you may be able to improve the situation by thinking about what that patient's experiencing before you have to start looking at what medications you might be giving to them. So thinking about environment, and if there's something that's agitating them, is there a stimulus that's driving this?
What is it that's making them so agitated?
Yeah, there will be probably something that could be thought about and changed before you start moving down this process towards medications.
Common ones that I think we see are, particularly in older confused patients, they can become agitated when they need to use the bathroom and they, haven't been taken and can't communicate that. And then, other patient groups being agitated about wanting to go out for a smoke is a really common one, isn't it? But if nobody's talked to the patient to understand what those issues are, then, it may escalate into something that's difficult to resolve when it could have perhaps been relatively easy to resolve earlier on. So all those non-pharmacological de-escalation is, I suppose, how we'd refer to that.
And for some patient groups, there's also things you might want to look at before you move further into this process, like whether there is a plan for them. So often patients, if they've got a learning disability, they are more likely to be someone who's also got a diagnosis of autism. Often plans for what you do with medication have already been set out for them. And that means that someone who knows them really well has thought about it. They might even know what's worked in the past. So it is worth taking a moment to make sure that somebody hasn't already thought about this and that there isn't a plan that's come with the patient, or a plan from the mental health liaison team about what to do and what to try first.
Yes, so having a bit of a look in the notes. So patients might have frequent attender plans or high intensity use plans from the emergency department that are available in the external documents on Sunrise. There might be progress notes from mental health liaison, or if the patient's a sort of learning disability patient from the community, they might have a sort of "this is me" or "what matters to me" document, or a sort of orange folder that has got that kind of information in. So trying to get somebody to have a quick look in those bits of paperwork is really helpful first, isn't it?
And often you might have come across some of that when you were thinking about what the legal framework is for the patient. Often this is a Mental Capacity Act kind of area. We get asked questions about children.
Yes, children are a bit more complicated, aren't they? And because the Mental Capacity Act only applies to those over the age of 16, and the deprivation of liberty safeguards only apply to those over the age of 18. So there are sort of slight odd gaps in the legislation around that. So for children, you might want to be thinking whether they're competent to make decisions if they're in that sort of older age group, or if it's unlikely that they're competent because they're so agitated, to think about who's got parental responsibility and who you might want to consult with before you're doing anything sort of dramatic. And then, like I said, the sort of 16 to 18 age group, it's important to remember that they can consent to treatment, but they can't refuse treatment. So that's a sort of a bit of legal framework around that that's important to remember.
Okay. So practicalities, you've thought about who the patient is, you've thought about whether you've got any information that might help you in that situation, and you've thought about what you can change before having to actually sedate the patient to see if you can create some change. What do we need to think about next? You phoned for senior help. Who else might you be thinking about phoning?
Yeah, so like we said, if you're in the emergency department or in the peds ward, you might want your consultant, if at all possible. You don't, if you're a junior doctor or a, junior member of the nursing team, you don't want to be doing this kind of stuff by yourself. You might also want to be thinking about the V&A team or the kind of rapid de-escalation team, who are the porters with experience in safe holding, who can come and keep the patient safe if they're being particularly agitated or, there's a risk of them harming themselves or other people. And so whilst you're thinking about whether or not we give this person medication, which would be the emergency sedation, you might want to use sort of, restraint or safe holding to keep the person safe.
Yeah, and I would say it's probably good practice to have a low threshold for thinking about calling that team, because they do have specialist training, they are very skilled and generally very helpful at keeping a situation which can start feeling chaotic. It'd be really helpful to have a group of people who really frequently do this sort of work turn up and input.
And like you said, they've had training, and as well as the safe holding, many of them are quite skilled in the non-pharmacological de-escalation bits of it as well, in terms of trying to help people calm down, aren't they? Because, like you say, they're very experienced. Yeah.
So we've got our patient, we've spoken to the right people, we haven't been able to reduce the risk, and we think that we might need to give the patient some medications.
Yeah.
What's the thought process when thinking about what we should be doing next?
So the first thought process should be, where do I get the information about what to give this specific person? So you've thought about who your patient is, are they young, are they old, are they big, small, and then you've maybe thought a bit about what the problem is. Are they a person with known mental illness on a lot of antipsychotic medications, or are they somebody who's, never had a mental illness in their life, they're delirious now, they've never had any exposure to any medications like this. So you've thought about your background patient. The first thing to do probably is to go quickly to the hospital emergency sedation guidelines and pick out the right algorithm for the patient that you've got in mind, because it's got very clear guidance on what drugs you might want to use for the different patient groups.
And it's helpful to have something, particularly in a chaotic situation, where it sets out the thinking step by step about the patient. Have they got a medical history that's relevant? That's all listed on there, so you don't have to try and remember all this. You've got something that you can reference repeatedly and go down the stages.
Yeah. Then the second bit is about how you're going to deliver them the medication. And carrying on with our sort of least restrictive principles, we should always be trying to give the person oral medication in the first instance, because if they're able to accept the oral medication, there really is not loads of difference in the amount of time it will take to work between the oral and the IM preparations. So it's not that giving somebody an injection will necessarily speed up the sort of rapidity of the sedation. So, an oral route is just much less restrictive for the patient.
So it's better for the patient if they can accept the medication.
Safer for the nursing team as well, because they're not trying to deliver an injection in a chaotic situation.
And understanding the absorption is actually more straightforward and slightly more predictable if it's taken orally, because that's how the medications were designed to be used. It's easier to judge the timings as part of that algorithm if they have been able to accept it orally. So it's worth pursuing that without anybody being at risk, but it is worth trying to approach the patient and more than once if you can, to try and see if they will take some medications. Perhaps it gets thrown the first time. It's worth pursuing that and making sure there really isn't an avenue.
And I think it also helps patients understand, that we're not immediately jumping on them and trying to give them an injection. We would prefer it if we could work together with them. And I think that is a kind of psychological thing that we're doing as well there.
Yes.
It's quite helpful.
So we're always going to try and start with tablets, and we're always going to try and start with a certain type of medication, aren't we? Regardless of the patient group, the first medication that we might try and use will be a benzodiazepine.
Yes, so that's first line for everybody. What dose you use will depend on your patient group and some of those factors that we were talking about, like the level of frailty or the size of the patient. But the one that we have of choice in the hospital, because it's available orally and IM, and it's got a relatively short action, is lorazepam, and everyone will probably be familiar with that as the kind of first line drug.
Yes, and that might range from 0.5 milligram for a child or a very old frail person. It might even range up to 2 milligrams if you've got somebody who you think is going to require a much higher dose for it to be effective, and that's all on the algorithm.
Yes. So, and it is worth also saying that very occasionally we do get shortages of these medications, and so whilst lorazepam is usually the first line on our algorithm, occasionally there are shortages and the algorithm will change and there'll be information about that. So it is definitely worth making sure that you've got the up-to-date policy up on the screen next to you. Yeah.
But we're looking for a benzodiazepine, ideally a short-acting one, because they tend to work faster, even if they don't last as long.
Yeah. And lorazepam takes about sort of 30 to 45 minutes to get into the system. And then it lasts for sort of 4 to 5 hours, maybe a little less.
So it's worth people understanding that just because they can give a patient some medicine, particularly even if they've had to inject the medicine, it's not all going to be better 5 minutes later.
Yes.
It's going to require people to stay on the scene, keep the situation safe, and some time is going to need to pass, and that patient's going to need care. How long do they leave it before they say this isn't working?
So around 45 minutes, I think, is the best kind of guidance. And then you may want to then have another go at giving your lorazepam again if they haven't responded to the first dose. So you've given it a decent amount of time to make sure it's getting into the system, and you're not accidentally going to over-sedate your patient.
Yes.
And if after 45 minutes, the initial dose hasn't worked, the guidance is different for different patients. So this is when it's important to have your algorithm up with you, because for children, after you've given your first dose, the advice is to seek senior advice, not to give any more. But for the working age and older adult age groups, you could give a second dose of your lorazepam, or you could choose your second line medications, which may be different.
And the second line medications, they are a different type of medication, aren't they? So that when you're trying to sedate the patient, you're trying to target different receptors.
Yeah.
So you don't just think about using higher and higher amounts of the drug, you also want to think about different drugs so that you have a better chance of creating that sedation.
Yes. And so the second line medications are, there's sort of two different options. One of them is an antipsychotic medication, that's haloperidol, that we use most frequently in the hospital. And the other one that we use alongside that, or alternatively to haloperidol, is called promethazine, and that's a sort of old-fashioned sedating antihistamine type medication. The nice guidance is actually that it's quite helpful to use those two medications in combination, because it gives you a slightly better sedative effect, and actually there's something about the promethazine that can take away some of the side effect profile of the haloperidol. So particularly if your patient is still very agitated, even after your first line lorazepam, it's worth thinking about whether or not it's appropriate to use those two together. Yeah.
And a patient could have those medications IM?
They could have them IM, or they could have them orally. And again, we would still try to offer medications orally. But all of those preparations are available IM and orally, which is one of the reasons that they're chosen for the emergency sedation. Yeah.
Is there a limit to how much medication patients can have?
So the guidance suggests that you seek, senior psychiatric advice after certain timeframes. So as I said, for children, that's after only one dose of the lorazepam. But for older adults, I think you can give up to 3 doses. And then after that, if the patient hasn't responded to the emergency sedation, then you should get hold of a psychiatrist. Now, in hours, that might be one of us, mightn't it, via mental health liaison. Or if you're unable to get hold of us, or it's out of hours, that would be via switchboard, and you can get hold of the on-call psychiatrist who can give advice.
So the main risks for using too much of the medication, particularly the benzos, that's respiratory depression. And it means you have to really think about the patient for the rest of the day, if not longer, if you've used high doses of the medication.
So there's certain, after you've given your emergency sedation, even if it worked the first time around, there are a few things that you should have in your mind. The first of which should be monitoring the patient, obviously. And again, the algorithm gives you guidance about doing that. But the sort of general advice is that, it's best to have somebody with them, but you should be doing some level of physical observations every 15 minutes for the first hour or so. That, if they're very agitated, that might only be a respiratory rate, which is kind of the important one that we're worrying about with the respiratory
depression. You don't need to be touching the patient or using equipment to do a respiratory rate.
Exactly. Yeah. But if you are able to get a full News or Pews score, then obviously that's more helpful. And then if there haven't been any concerns, you can sort of step that level of observation down. But the guidance is that you carry on doing half-hourly obs for the next 12 hours, which is, perhaps not something that people might necessarily expect. The other bit of advice that we give is that for anybody who's received emergency sedation, the mental health liaison team should be alerted, because we may be able to change the care plan or change the regular medications for somebody so that they don't need repeated doses of emergency sedation.
And if they're a patient with a mental health problem, because most clinicians here can't access the psychiatric record, there may also be really helpful information about what had helped in the past in other situations like this, and it can avoid the need to go back and repeat this behaviour the next day.
So we talked about certain patient groups where you might want to do slightly different things. We've talked kind of generally about frail patients or elderly patients or children. I suppose there's another specific group, which are patients with Parkinson's disease or Lewy body dementia, and we would generally not advise that we give them the antipsychotic part of the emergency sedation.
Yes, so the antipsychotic part is often the bit that gives people the most concern about using the medications. They're more difficult to predict in patients where you've never given them an antipsychotic before. You don't quite know how sedated they will be. They're the medications where people also have concern if the patient's perhaps got a cardiac history or an abnormal ECG, which is obviously not unusual, particularly with older patients. Patients where Parkinson's or Lewy body dementia, where dopamine is relevant, because that's one of the big effects of an antipsychotic. It affects the amounts of dopamine in specific areas of your brain. You can make that much worse. So a Parkinson's patient, even if they were agitated and confused, you might be better off using much higher levels of benzodiazepine than mixing up your medications, because you're likely to make their Parkinson's symptoms much worse, and it wouldn't just be affecting their mobility. If you cause them pain in their muscles and dystonia, you might increase the agitation anyway.
Yes, might make everything much worse.
It might make everything much worse. And I think if you are having to give emergency sedation to a medically complicated patient, again, we'd advise you to be contacting us in the mental health liaison team, so we can think about whether we need to make an adaptation to the algorithm, but that really should be done with senior clinician oversight.
So some other practicalities, we talked about getting the site team involved, getting your own senior clinicians involved if at all possible, contacting mental health liaison team. Practicably, thinking about how we actually get the drugs or, how we deliver an IM injection, it's worth thinking about. So first off, there are emergency sedation boxes in the hospital, and I think they're on AMU, in ACUC, emergency department, Knightsbridge and 7A, so spread throughout the hospital where these drugs would be available for use out of hours.
Yes. You don't have to wait for them to come out of pharmacy.
No, exactly. And then the second bit about sort of how you actually give an IM injection, I think that's something worth thinking through, isn't it, if you're needing to do that. So you've got all those people available to you. What will actually happen if you're doing an IM injection?
So I think what's important to recognise is not everybody can be putting hands on the patient in an emergency situation. It can be risky to be approaching a patient, particularly if they're confused or if they're very agitated, and you can put yourself at risk. Absolutely. And that is a very unhelpful thing to do, because then you've got two patients, not one, and that's not what's needed in an already an emergency situation. So you have to make sure that you've got people there, such as the VNA team, who have got specialist training to know how to be in physical contact with a patient who might need emergency sedation. So even if you are very familiar with the patient, if you're not trained in how to do this, you shouldn't be doing it. And actually your insurance probably doesn't cover you to do it.
Yes, you're more likely to either injure yourself or the patient.
Yes.
Aren't you? Yeah.
So when patients have to be given IM injections or other interventions in this situation, they have to be held in a specific way. They have to be held in a specific way so that they don't get any injuries, and they have to be held in a specific way that is safe for the staff that are holding them.
Yes.
So the sorts of positions where patients have to be, it's often on a bed, although it can be done seated depending on what the patient needs. And again, it'll be the V&A team who will be able to lead and deciding on the position. But they have to be securely held. They might have to be held for a long period of time, which means you don't want to be caught in a situation where you can't comfortably or sustain the help you're giving to the patient. So the V&A team really should lead on who's doing what. And they will have a conversation before they approach the patient about who's going to be doing which part. The medication has to be administered into a muscle. It doesn't have to be a specific muscle, but there are ones that are preferable, major muscle groups.
Often the shoulder or the outside of the thigh or their buttock, isn't it?
And again, how the patient is held in the right position needs to allow for that, and it needs to allow for one of the nursing staff to be able to administer it. So you can't all just go in there, be helpful. It has to be thought about, and the patient has to be held in the right way. Patients who are held in the wrong way, incidents have happened in the past where patients have been held face down on a bed, for example.
Very dangerous.
Very dangerous, particularly if you're giving patients drugs that can affect their breathing, such as lorazepam.
Yeah, and so typically with the team, like you say, they would plan it, and it's usually one person per limb, isn't it? And then maybe somebody supporting the patient's head. You'd have somebody talking to the person to explain to them what you're doing, and it should be a separate person. So you would probably have 6 people altogether, wouldn't you? So one person per limb, one person to talk to the patient, and a registered nurse, obviously, who needs to administer the injection. And so it's, and like you said, it needs to be a planned thing. You want to have your medications drawn up beforehand. You don't want to be sort of rushing off to do that whilst
once the
you're about
patient's
to
being
do
held
it.
down.
Yeah. So, and I think other bits and pieces. Obviously, you're trying to practicably keep the rest of the ward safe. So you might want to move other patients out of the area. You might want to try and get screens to maintain the patient's dignity, and get them into a side room, I guess, if at all possible.
Ideally, a side room. Hallways are not ideal, even if the situation feels very out of control. And certain areas like patient bathrooms just aren't safe. But it can't be you that moves the patient. Again, you should be speaking to the V&A team about anything that involves putting hands on the patients.
So you've done all of these bits and you've informed all the right people, and hopefully your patient is calming down. You've got, for adults, 3 episodes of this that you might have to go through before that might happen. What happens if you've done that, you've spoken to the on-call psychiatrist, whatever the advice they've given is not changing the situation, and the patient is being restrained for really prolonged periods? What might happen then?
So there is limits to how long you can restrain a patient for, and there is limits to how much of these medications you can give people before the risks start to outweigh the benefits that the medication might be offering you. At that point, there is a more difficult decision to be made, which is, can that patient remain in that environment?
Yeah, and so I think the final backstop, really, which you have available to you in an acute hospital setting, is that the patient's anaesthetised, isn't it? So that would be calling the critical care team to ask for sort of a rapid induction anaesthetic. But that's obviously, an absolute backstop that we would try to avoid, really.
Yeah, I think that has to be the last case scenario. And there are times where people may move towards that more quickly. Sometimes you see certain patients that have had head injuries and they're very agitated, for example. But the most common use of emergency sedation for that sort of patient group, you would need to extensively demonstrate that you had tried these less restrictive options before. And you absolutely can't jump ahead to that stage just because
it's convenient.
And you predict that the patient won't agree. It can be challenging to look after some mental health patients, but this process needs to be followed. You can't just jump ahead and ask a critical care team to come and make your patient unconscious. And you need to be very thoughtful about that, even if it's an emergency.
Yes, I think there's a very significant risks attached to that are, there are risks attached to emergency sedation, but the risks attached to intubation are obviously much greater.
Yes.
Yeah. So I think that the main thing about this is to, make sure that you're familiar with, or you know where to find those algorithms, isn't it? Because, as we said, we haven't given you advice about doses or anything like that. That is really not something that you would be thinking about as a kind of blanket. It's something you need to decide on a patient-by-patient basis.
Yes.
And then just thinking about the team who's around.
Yeah, so when the situation has changed and the risks are lower, you've set your plan for how often the patient might need observations. There's two other things that you might want to think about doing to conclude the situation. So the first one is thinking about having a debrief.
Yeah.
It can be really distressing, particularly if this was very unpredictable or staff members were involved who hadn't been through an episode of care with a patient before where really restrictive care was needed. But it also gives the opportunity to think about, well, what was the start of this process? Was there something we can do differently or change so that we're not likely to end up in this situation the next day or whenever those medications wear off? So aside from supporting staff, there is an opportunity to really think about that patient and think about, well, if we did have to do this again, what worked well, what didn't, what should we do differently? And you've got some time then to speak to other people if you need advice about decisions that you had to make in a difficult situation. And the other thing is, I think we have to do a report, a DATEX, if we have had to restrain a patient.
As you said, the site team should be called, and I think one of the things that they should coordinate is who completes the DATEX about the incident, so that they can be tracked and discussed and make sure that the hospital are responding appropriately, isn't it?
And it doesn't mean that you've done something wrong, it's just that these situations really matter and we need to be able to think about them.
Yeah. Okay.